is Dr. Chathura. He's the consultant dermatologist at Teaching Hospital Goal. Sorry for the delay. Thank you very much, Chathura, for accepting our quick notice. And we'll start the session without wasting any more time. Thank you, Chathura.
Thank you very much. First of all, I thank you for giving this opportunity to me over a short notice. And I see there are a lot of participants despite the short notice and being on a Sunday night. And it's especially relevant today, being that today is actually World Leprosy Day. So without much ado, I think we'll start with the session. I'm going to start sharing my presentation now. Just give me a second. Just see what you can see my screen.
Puta.
You can. So today I thought of talking about leprosy or Hansen's disease as it's known. Because it is quite challenging to diagnose, and our aim at the leprosy campaign is mainly to get the numbers down as fast as possible. So I think it's very important that we have a proper idea of the possible manifestations we can have in leprosy, because it's so wide and varied. It can present in so many different ways, as you'll see during the journey of this lecture. In addition, I thought, in addition to leprosy, I'll talk about other common skin conditions to help you distinguish the two. So, what is leprosy? So, leprosy is a chronic infection caused by Mycobacterium leprae and the recently identified Mycobacterium lepromatosis. It's essentially a disease of the peripheral nerves and the skin. It can, however, affect all organ systems except the central nervous system, that is the brain and the spinal cord, and the lungs and the ovaries. Now, here you see the Mycobacterium leprae Bacillus, which is stained red, adjoining a nerve fiber. So, a lot of people ask me, is the incidence of leprosy, why is it going up recently? So, these details have been provided to me kindly by the leprosy campaign, and I work as the dermatologist at the Central Leprosy Clinic of the National Hospital. As you can see, there is no significant increase. There has been a dip during the COVID pandemic, which is similar to the dips we see in other countries worldwide. And it's more or less, I think it's either stable or on a downward trend. So what is Mycobacterium leprae? So it is a gram-positive rod, Arabic, and it's an obligate intracellular parasite. Now, it doesn't survive everywhere in the skin equally. It prefers the adnexal structures of the skin and the Schwann cells. I'll talk about what that is down the lecture. And also, it prefers a slightly cooler temperature than the body temperature, that is 32 to 34 degrees centigrade. That's why we never usually see leprosy lesions coming up in the axilla or the groin or the hair-bearing scalp, because these are warm areas. We usually see lesions on the earlobes and the acral limbs. It has a very long doubling time, and as a result, it has a long incubation period. Now, the reservoir is actually untreated leprosy patients, whom we call multibacillary leprosy patients. Now, in certain countries like America, they have also identified this guy, the 9-banded armadillo, which can act as a reservoir host and which can spread the disease subsequently to humans. Now, according to the currently established facts, this is spread via respiratory droplets of untreated patients. However, you need a prolonged contact. Now, we call a close contact or a prolonged contact if someone is exposed to another person 20 hours a week for at least 3 months over a given year. So, as you can see, that's a long period. You don't catch leprosy by using a household utensil of like a cup or saucer someone used. And it usually has a low infectivity, as majority of us have inherent immunity against this organism. Only about 3 to 5% of patients who get the bacillus in develop the disease. So how does it get through? When we inhale the bacillus, it's taken up by the pulmonary alveolar macrophages or PAMs, and then it's disseminated through the bloodstream to the nerve and the skin. And the bacilli then proliferate, especially in the Schwann cells. And depending on our immune status, now since this is an intracellular organism, our humoral immunity with antibodies doesn't play much role. It's the cell-mediated immunity that plays a significant role. So depending on the effectiveness of our cell-mediated immunity, we can either get a natural resistance or clearance, or we can develop a transient state called indeterminate leprosy, which can further go to natural clearance or go on to develop symptomatic leprosy. So clinical features are like a spectrum. That's what you see at the bottom in multiple colors. We call TT or tubercular leprosy, borderline tubercular leprosy, mid-borderline leprosy, borderline lepromatous leprosy, and lepromatous leprosy. So it's actually a spectrum, not discrete parts like this. So if you have a good cell-mediated immunity, then we go to develop what we call tubercular leprosy. In contrast, if you have a poor cell-mediated immunity, you will go on to develop what we call lepromatous leprosy. So in tubercular leprosy, you will have only 1 or 2 lesions because your immunity is good. They will be well demarcated. They'll have only very few organisms. So if you do smears, you won't see any organisms. In contrast, when you go to the lepromatous leprosy side, hundreds and hundreds of lesions. It's more like a systemic disease, and they are teeming with bacilli. That means there are a lot of antigens, and as a result, a lot of antibodies formed in the body, but they are ineffective in controlling the disease. Nerve damage due to leprosy can occur in any of these states. In tubercular leprosy, it's due to the inflammatory response, which damages the nerve, and in lepromatous leprosy, it's due to the direct invasion of the organism. So before we go on to the clinical features, I thought it's important to discuss the skin anatomy. Now, as I said before, I spoke about that the organism likes to live in the skin adnexal structures. What are these adnexal structures? That is the nerve endings. Then you have the hair follicles, the sebaceous glands or the oil glands, and the sweat glands. So the organisms live mainly in these structures. And of course, the melanocyte you see in the picture on the left also plays an important role in the deep hypopigmented lesions we see in leprosy. So what happens when you are infected with leprosy? So it's essentially like a war between the patient's cell-mediated immune response and the virulence of the bacillus. And as in any war, there is collateral damage, that is harmless bystanding structures can be damaged. So as a result, now when the nerve endings are damaged with the bacteria being there, when you have a good immune response, you can get an anesthetic patch. It's also important to note in the very early stages when the nerve is just inflamed and not fully damaged, you can have hyperesthesia or increase in sensation. And further on, the first thing we lose is sensory loss to temperature. Touch and pressure go later on. So pain and temperature goes first. So as a result, especially in highly innervated areas like the face, if you just check with a toothpick, you might miss the sensory loss in an early stage. Then damage to the sebaceous glands will result in dry, scaly patches of skin, the lack of sebum. Sweat gland damage will lead to anhydrosis, loss of sweating, and then there will be loss of the hairs. When there's a good inflamed leprosy patch, like in tuberculoid leprosy. Damage to the melanocyte can occur in several ways, and relatively the number of melanocytes in leprosy patch become reduced due to the inflammatory process, loss of trophism by the nerve endings, because melanocytes are also dendritic cells of neuroectodermal origin. So when the melanocytes become reduced, they become hypopigmented. This is in contrast to vitiligo, where there's autoimmune destruction of all melanocytes in the patch and the lesion gets depigmented. We'll talk about this later on as well. So moving on to the clinical features. I mentioned before that one of the first signs we might see in a patient is what we call indeterminate leprosy. Indeterminate means undecided. So some people get a transient state where you get 1 or multiple ill-demarcated hypopigmented patches. Sensory loss may or may not be present. And even for us as dermatologists, it can be quite difficult to diagnose because they are very transient, very small patches, usually on exposed areas like the face or arm or upper limbs or even on the thigh or buttocks. And this can resolve spontaneously. So you can see how vague and non-specific it looks. So here are some more pictures of indeterminate leprosy. So it's quite difficult to detect it at this stage. So moving on, that spectrum I showed you, when our cell-mediated immunity is at the maximum, what we get is, if you go on to develop the disease, what we get is tuberculoid leprosy. As I said before, it's well demarcated. You'll have only few patches, very stable, and it can be sometimes inflamed and slightly red or copper colored due to the good immune response. It'll be dry, hairless, anesthetic as I described before. If you do a smear from this, it will be negative. So this is more like a localized disease, right? Uh, so this is another picture you can see in the nape of the neck. It's not extending inside the hair because the scalp is a warm area, as I mentioned at the start of the lecture. So here we see it involving the ring finger and the middle finger. Sometimes it can lead to swelling of the digits, which we call dactylitis. So leprosy is one cause of dactylitis as well, where you can get uniformly swollen, sausage-shaped digits. So you can see a solitary patch involving the lateral aspect of the right eyebrow, resulting in the loss of the or thinning of the eyebrow. So in children, now they can't tell you that the patch is anesthetic, especially in younger children, but they will notice a change in the sensation. So they will be always touching this patch. So parents might think that this is an itchy patch, when in reality it's not itchy, that it's just the child is trying to tell you something that you can't feel it. So be aware of that. Don't think it's a itchy patch and get misguided. And recurrent rubbing or touching might even lead it to be hyperpigmented. So don't be misguided by that. So moving down the slippery slope, next we have the borderline tuberculoid leprosy, where your cell-mediated immunity is a little bit lower. It's a lot like tuberculoid leprosy, but the patches are larger, maybe slightly less ill-demarcated borders. Sometimes we see satellite lesions, where separate discrete tiny islands beyond the main patch, or like what we call pseudopodia. Like in amoeba, you can have parts jutting out from the main lesion. Often they can be having associated peripheral nerve thickening in the vicinity of the lesion. And nerve damage is also quite common in this type of lesion. So here is a patch of borderline tuberculoid leprosy. You can see a hypopigmented patch. The margin is ill-demarcated. It's a reasonably larger patch than what I showed before. And what is this dark brown ulcer-like lesion, like a cigarette burn in the middle? It's almost an eschar. So what happens is, as I said, these are anesthetic. So often they present with burns, right? So burns heal with these blisters or scars. They can present with multiple bullae due to the burn blisters, or healed scars like this. So this also should be a clue of anesthesia. Right? So anesthetic hypopigmented patch. So this is leprosy. So sometimes it can be more difficult when it's less hypopigmented. Can be more scaly and even can be mistaken for other conditions like eczema. I'll show you further pictures as we go along. So in these conditions, as I said before, in the vicinity of the borderline tuberculoid leprosy, you can see thickened nerves. So on the right side, you see a patch near the angle of the mandible, a dry scaly patch, and the thickening of the great auricular nerve on the left side, that is. And on the right side, you can see some thickened cutaneous nerve twigs, which have been shown with an arrow next to the patch of leprosy. So often these nerves we have to feel. They are only you can't always see it. You have to palpate the ulnar nerve, the sural nerve, peroneal nerves, and often you can feel it like a rubbery thickening, irregular thickening. So moving on, then we have the mid-borderline leprosy. So these lesions are gradually now we are losing the cell-mediated immunity. So you will see bacilli when you do stains or smears from this. And they have this typical characteristic appearance. We call it an inverted saucer shape. That is like you take a saucer of a teacup and turn it upside down. You get a central punched out circular depression, elevated margins which are gradually sloping outwards. So this is typical of mid-borderline lesions. So sometimes it might not look so obvious, but you can see the central depression and the slanting margins. So here are some more pictures. Now you can see the lesions are becoming more and more multiple with lesions on the upper limb as well. Here is a larger lesion with central dermal plaques as well. So going further down, now the immunity is getting lesser and less, and it's a systemic disease. You can see multiple patches which are having ill-demarcated margins, which are gradually fusing together. And they're also hypopigmented or coppery colored. And the sensory loss may not be as marked as in the tuberculoid patches because the immune response is less and nerve damage is less. And smears will be positive at this stage. So you can see further borderline lepromatous leprosy lesions. So they can be flat lesions or more thickened plaque-like lesions. So you can see sometimes you can even miss these for things like Peters's versicolor as well. Sometimes they may be more elevated and palpable lesions. You can see here, donut-shaped lesions. Overall, they are still quite asymmetric, although quite widespread. Sometimes they can present with just dry ichthyotic skin as well. So it can be quite challenging to diagnose. So it's important that we have an open mind when we see such patients. And finally, lepromatous leprosy, where your cell-mediated immunity is the least. So it's now a generalized disease. It can affect multiple organs. So not only in the skin, they can have involvement of the respiratory tract, damage to the nasal cartilages, and collapsing of the nasal bridge. They'll end up with a saddle-shaped nose, and they will have a diffuse infiltration of the face, and the face gets thickened. So like a face of a lion, we call it a leonine face. But loss of eyebrows, we call madarosis. And, they can have testicular atrophy, gynecomastia, basically peripheral neuropathies. Most organ systems in the body can be involved, right? And they'll be strongly smear positive. So lepromatous leprosy they also will have respiratory tract symptoms, and they will be shedding the bacilli with their nasal secretions. And even laryngeal involvement, eye involvement can be quite common, and we have to have a high index of suspicion in these patients. So also, now in this patient, I put the picture to show the leonine face and the saddle nose. You might notice that the skin is quite pigmented in this patient, like a mahogany color pigmentation. That is a response to actually the treatment and not leprosy itself. This patient is on treatment for leprosy, and this is the color of the clofazimine pigmentation, the clofazimine drug, which I'll talk about later on. So now this patient came to my clinic. She came for an unrelated problem. But if you look carefully, she looks quite young for her age. There are no wrinkles. And if you look very well, you can see that she has lost her eyebrows, which she has penned in with an eyebrow liner. And there are tiny papules near the submental area, near the chin, perioral area, tiny dermal papules. So this is a diffuse or infiltrative form of leprosy, which we call lepra bonita or beautiful lady. Because what happens is in these patients, you get a diffuse infiltration of the skin with the bacillus and the foamy macrophages and all the inflammatory cells. So it fills up all the wrinkles. So they look young for their age. Hence the term lepra bonita, which means pretty lady. Unfortunately, when we start treating them, gradually the wrinkles will appear. So our people spend millions to inject themselves with artificial synthetic fillers, and here leprosy is doing the job for you naturally. So here further pictures of diffuse lepromatous leprosy. So sometimes it can be quite challenging to identify these patients because the skin just looks infiltrated. Now, although we talk about thickening of the earlobes, you can see it's very subtle on the picture on the left. And if you look on the picture on the right, it's so easy to miss. The hypopigmentation is very well demarcated because there's a very poor immune response. It's only gradually losing the color. The only clue is if you look carefully to the margin of the lesion, you can see sweating, whereas there is no sweating inside the patch. So there's a compensatory hyperhidrosis just outside the patch with hypohidrosis inside the patch. So that is the importance of this is these patients are infective because they have a poor immune response. The skin is diffusely infiltrated. If you do smears, they'll have a high bacillary load. So that is why it's challenging sometimes to identify leprosy patients. So even if we talk about thickened earlobes, if we don't look carefully now, this patient who came to my clinic, if you turn the earlobe the other side only, you'll see the tiny nodules. If you don't look carefully, you might miss it. So these are the nodular variants of leprosy. You can see, you can even mistake it for other conditions. We'll talk about it later on. So this is also nodular erythematous leprosy. You can see thickening uh, erythematous lesions on the face, earlobes, and tiny papules and nodules. This is another variant we call histoid leprosy, which is quite infective actually. They present with these dome-shaped, skin-colored or slightly pinkish nodules and papules, which are firm to touch. And if you do smears, they are strongly positive. So we call this histoid leprosy. You can see the lesions on the earlobes, on the cheek, which almost looks like acne cysts. We have some more lesions of histoid leprosy, but here it's more obvious. So here are some more lesions. It can be quite numerous. Then about 5 to 10 patients of all leprosy patients will only present with what we call pure neural leprosy. They won't have any skin lesions, but they will come with a claw hand or neuropathic ulcers, so they can easily be missed. I hope what I have said thus far is clear. If it's not clear, please drop a message. I'll try to answer at the end. So now moving on to the complications of leprosy, we talk about lepra reactions, which are immune-mediated reactions. And then we talk about other complications later on. So we talk about a reversal reaction or a type 1 reaction. The type 1 reaction is for various reasons. Your cell-mediated immunity suddenly goes on the overdrive. It improves. So suddenly your pre-existing leprosy patch will become inflamed, red, painful, right? You can have acute nerve palsies like that, right? So the reason is your cell-mediated immunity has suddenly improved. It can be maybe after viral infection, after vaccination, so on and so forth. Sometimes this is the way leprosy patients may present because they might not notice the initial hypopigmented patch, which might be very subtle. When they get the inflammation, suddenly over it might be over a few days, maybe 1 or 2 days, they suddenly get this very painful swelling and they come with the reaction. So you might also mistake it for cellulitis or other things, right? So be aware of that. So for this sort of thing, we often have to treat with either NSAIDs, steroids, immunosuppressives, and we have to be very careful because they can develop acute nerve palsies. I'll talk about them later on. This patient can develop leg of thalamus, weakening of eye closure due to sudden nerve damage. So here also you can see sudden swollen red plaques, right? So it's due to the reversal of your immune response. So your cell-mediated immunity gets better. So this is actually what we call a type, in the Gell and Coombs classification of the immune responses, this hyper or sensitivities, it's a type 4 delayed type hypersensitivity reaction. So who will get it the most? Any idea? Is it the lepromatous people, tuberculosis people, or anyone else? Now, we know tuberculosis leprosy people are at the extreme. They have the best cell-mediated immunity, so they can't improve it any further. So the people who are more likely to get type 1 reactions where their cell-mediated immunity will improve will be the borderline tuberculoid people. They can move further on the spectrum towards the tuberculoid, but other people are less likely to get it. The type 2 reaction is due to circulating immune complexes. We call it erythema nodosum leprosum. Just like erythema nodosum, very similar. So they also present with subcutaneous nodules, which can be tender. But unlike erythema nodosum, these can ulcerate. They are smaller and they can even occur on the upper limbs. So not only on the legs, but also on the upper limbs due to cutaneous deposition of immune complexes. They can have also involvement of the other organs like glomerulonephritis, arthritis due to the immune complexes. So who are more likely to get this? So you can see sometimes quite tricky to diagnose. No? Even here, if you look, it looks like insect bite reactions. But unlike insect bite reactions, they are not itchy, they are painful. Patient might be ill, having fever, and if you check a ESR will be elevated, and if you do a biopsy, it will confirm. So who will get this? Most likely. Who has the highest load of circulating immune complexes? They are the lepromatous leprosy patients. Right? So I hope that is a little bit clear. So this is what we call Lucio phenomenon, which is fortunately rarer in our countries. This is seen in diffuse lepromatous leprosy. It's actually due to proliferation of the endothelia within the blood vessels due to multiplication of the bacilli and vaso-occlusion and necrosis of the skin occurs. They are highly positive. So another way these patients present is with neuropathic ulcers. Now the commonest thing you will see these presentations are obviously in diabetes. or the causes of peripheral neuropathy. But bear in mind, if you get a patient, a relatively young patient, maybe even diabetic, but reasonably well controlled, coming with from an endemic area with leprosy, just think at the back of your mind, would this patient concurrently be having leprosy as well? Right? Because we can't afford to miss it. So usually if diabetic is very well controlled, short duration, young patient, unlikely to cause this degree of ulceration, isn't it? So keep that in mind. So they can also present with foot drop. Now, if you look at this patient, you can see the patient is dorsiflexing the ankle on the left side, but he cannot do so on the right side. And even the toes are pointing downwards. And if you look carefully, there's an ulcer near the metatarsophalangeal joint on the right side where the foot is hitting the ground when he's trying to walk. So this is a foot drop secondary to leprosy. So they can come with claw hand, claw feet, and this is what we want to prevent. Actually, this is a more, you can see a more established lesion with contractures. So the idea of diagnosing leprosy, detecting leprosy early is to prevent all these comorbidities and complications from occurring. And obviously to prevent the spread to other people. They can present with nerve abscesses as a part of the reversal reaction. When I said their immunity goes on the overdrive, it's a part of the type 1 or reversal reaction. They can get a sudden severe inflammation and swelling of the nerves, and this can lead to acute nerve palsies. You can see how the ulnar nerve has swollen up. It's a restricted place in the olecranon groove. So it can lead to ischemic necrosis of the nerve. So this is an emergency. Again, you can see the swelling of the median nerve in this patient. So these are emergencies. We are here to treat them with high dose steroids, surgery, for incision and drainage and decompression of the nerve, and also and concurrent antibiotics if necessary. And if you don't do this patient is going to get permanent contractures due to nerve palsies. So sensory loss. Now, if you look carefully, the hands on the left, you can see the fingers have got blisters, right? So this indicates a peripheral neuropathy, at least involving the fingers. Often they can come with burn injuries. Housewives commonly come this way with leprosy when they have peripheral neuropathy with these blisters. So don't mistake it for immunobullous disorder or porphyria or anything like that. So another way actually leprosy patient present are with bilateral ankle edema, swelling of the lower limbs. Now when we get patients in our clinic with ankle edema, what do we think of? Commonly we think of liver disease, renal disease, heart failure, isn't it? So, but don't forget, I've actually seen even sometimes even consultants can miss this. So they check for everything under the sun. But what we forget is, the autonomic nerves are also involved. And if you're having leprosy, which is not very apparent, what happens? So when you're standing for long periods, the reflex vasoconstriction does not occur. The vasodilatation and fluid leakage leads to swelling of the uh, bilateral lower limb. So these are actually a leprosy patient. So we mustn't miss patients like this. I've seen several like this actually. So bilateral leg swelling. Don't only think about the classical causes. Think, can this be leprosy, especially if everything else has been ruled out. So we talk about, colloquially we say angeli helena, the rigid fall off in leprosy, but that's not actually what happens. So repeated microtrauma, autonomic neuropathy leads to bone resorption from the terminal phalanges and the digits gradually get shorter. In addition to this, you can also have digital microtrauma, repeated trauma leading to shortening as well, right? So you can see the disability it can cause, right? So another dreaded complication is leg of thumb. So when the leprosy affects the, eye muscles, you get, leg of thalmus where you can't close the eye even if you try to blink. So the cornea gets exposed and you get exposure keratitis. And the corneal scarring results in permanent blindness. This is only one way you can get blindness in leprosy. There are so many other ways they can get uveitis, so many other ways. So we have to be very careful with our leprosy patients to make sure we are not missing anything. Right? So again, leg of thalmus is something we want to prevent rather than wait for it to happen. So I'm not going to talk much about our disability assessment in leprosy, but bear in mind if you get a visible disability like motor weakness or say blindness or foot drop or whatever, it goes as a grade 2. So this is what we are trying to prevent. This is not one of our patients, fortunately. I got this from the internet. So you can see the amount of disability, stigma this can cause. So you can see the leg of thalmus, corneal scarring, blindness, madarosis, nasal bridge destruction, to name a few of the deformities she has undergone. So, how do we diagnose leprosy? So, now leprosy is primarily a clinical diagnosis. Unfortunately, there are no specific tests you can do. There are certain at research level, but we cannot use them because they are not very reliable. So, we will go for the cardinal signs of leprosy. So, even if one of those are positive, we take it as leprosy. So, either you have a hypopigmented or erythematous skin lesion with definite alteration of sensation, right? Or you have involvement of the peripheral nerves as demonstrated by thickening and loss of function. Now, bear in mind, nerve thickening alone without loss of function is not leprosy, right? Now, nerve thickening can be due to so many causes, isn't it? Don't only think about leprosy, diabetes, acromegaly, HIV, then hereditary sensory motor neuropathy, Charcot-Marie type 2, isn't it? CIDP, so many things, amyloidosis. But also, in addition to these, you have to think of leprosy. But leprosy is one of the few causes where you get irregular, like sausage-shaped thickening of the nerve. So when you palpate the nerves, go along the length of the nerve. Don't just touch one area because you get skip lesions. Unlike in the other cases where you get diffuse nerve thickening, in leprosy, you get irregular, lumpy thickening of the nerve. Some areas may not be thickened. So when you go along the olecranon groove for checking the ulnar nerve, go proximally along the nerve as well to see whether the nerve is thickened. So also, even if you don't have skin lesions or to see if you do a nerve and if it's positive, then also you can diagnose leprosy. So when we do a smear, this is what we see. So the tissue fluid is taken and stained. There are several stains we can use, Fight stain or Ziehl-Neelsen stain. And this is what we don't want to see rather. So you see these cigar-shaped bundles, lobi as we call it, of the bacilli, which are rods which stick together, right? So in our clinic, the Central Leprosy Clinic at the National Hospital, this is the report we give when we do the smear. So we look for two figures. We call it the BI or the bacillary index, which is a logarithmic scale you see on the right side. So it's the power of 10. So plus 4 has 10 times more bacilli than plus 3. So on and so forth. And MI, which is the morphological index, which is a percentage of the live bacilli we see at the time of staining. So that is a percentage. So at the end of treatment, the MI should obviously be 0. You shouldn't be having any live bacilli. But the body can take quite a while to clear up all the dead bacilli. So the bacillary index may still be positive. So now we'll move on to the differential diagnosis of leprosy. This might be important in your day-to-day practice if you see patients. So now we spoke about all these lesions, isn't it? Hypopigmented patches, erythematous scaly plaques, non-leaning ulcers and nodules. Let's go and see what are the differentials we need to consider. So one of the common things, I think I mentioned this before also during the lectures, aluhang or pityriasis versicolor. So it's caused by a yeast called Malassezia furfur. You can have either hypo or hyperpigmented lesion. Now, why does that happen? Now, this yeast produces a chemical called azelaic acid, which is a bleaching agent. So the same bleaching agent can be found in some of these whitening creams ladies rub as well. So that's one of the causes. That's how it causes the lightening. This azelaic acid, a bleaching agent. Now, this organism grows in the pilosebaceous unit or around the hair follicle. So as a result, the hypopigmented patches are mainly around the hair follicle. It's perifollicular. It's common on the trunk, face, and arms. Now, often patients say it can be little itchy, especially after sweating or after a bath, it can be little itchy. Now, bear in mind, leprosy is usually never itchy, except in reactional states. So, if you get an itchy lesion, it's unlikely to be leprosy. So, here's a bit of a more clearer picture. You can see it occurring around the hair follicle. So, the hypopigmentation is around the hair follicle, right? So, you can see now this is a patient with leprosy. So, you can see it can look like aluhang, isn't it? But there is a giveaway here. You can see a dermal plaque in the right posterior shoulder. So that is a clue. Sensory loss may be vague because this is more towards the leprometer school, so they are not well demarcated, and it might not be that the sensory loss may not be that much. Now the thing is vitiligo. Now vitiligo, as you know, is due to autoimmune destruction of the melanocyte. I spoke about this early in the lecture also. Now here it's complete destruction of the melanocyte, so the skin is depigmented. Whereas in leprosy, only some of the melanocytes are destroyed. So it's hypopigment. So you won't see pink patches like this in leprosy. You'll see only a slightly lighter color. In addition, in leprosy, you won't see leukotrichia or the white hairs we sometimes see in vitiligo. You won't see that. So just to, as a teaching purpose, I put two slides. The top one is Pityriasis versicolor, where you get the perifollicular hypopigmentation. Bottom one is vitiligo, where you see perifollicular sparing of the pigment. So they are like mirror images, because in vitiligo, the hair follicles have stem cells which give new melanocytes. When the melanocytes are being destroyed, the stem cells in the hair follicles replenish them. So they are the last to lose the pigment, so the hair follicles still retain their pigment. So their perifollicular pigmentation is seen, whereas in Alba, perifollicular hypopigmentation. Another condition we can't afford to miss is what we call cutaneous T-cell lymphoma. It's also called mycosis fungoides, but it's not a fungus. So they present with hypopigmented patches and plaques, commonly on sun-protected areas like the breast, buttocks, armpit, and groin. As I said before, armpit and groin are warmer, so you won't get leprosy there. Often these are mistaken as aluhang, and these people miss their treatment and delay diagnosis, which is not a good thing for a lymphoma. So you can see how it looks like. In our clinics, we do get 1 or 2 a year at least. So it's important not to miss. So this is what leprosy looks like. So you can see is on the buttock, which is another common site you can get leprosy. So you can see it can be quite similar. Another common condition of hypopigmentation, especially in the older children, is what we call Pityriasis alba. They present with ill-demarcated, dry, scaly patches. It's worse, especially towards the time you do like march passes, sports meet. Sunny times, you can see it more. It's often associated with dry skin and eczema. There won't be a sensory loss. But as I said, in the face, sometimes it can be tricky because leprosy early stages, you may not see a sensory loss. Right. Then polymorphic light eruption, again, which is caused by the sun, will have central hyperpigmented areas surrounding hypopigmentation. It will be dry, scaly, but there won't be sensory loss, and it is usually itchy. Again, common in the sun at the time when the sun is the highest, like in April, after sports events. Another common condition in young adults, we call it progressive macular hypomelanosis. This is again mistaken as Pityriasis versicolor. So young adults, 20s, 30s, they come with this lesion. It's common to have this hypopigmented confluent areas in the central back near the spine and paraspinal areas. Gradually, they become small and more discrete patches are seen. The exact cause is unknown. It's thought to be a reaction to the some of the organisms in the skin. So we treat this with either phototherapy or benzoyl peroxide and clindamycin. Now, sometimes this nevus depigmentosus can be mistaken for leprosy, but it's easy to distinguish if you ask the proper history. This is often from a very young age or from birth, actually. So you can distinguish, and they will have irregular, bizarre borders. Another thing is tinea, because this is a very common condition as well. But again, this involves the axillae and the groin, so which is unlikely in leprosy. And usually it is itchy unless if you have applied the steroid and have made it tinea incognito, where it won't be itchy. So sometimes it is a bit tricky. And leprosy, just like leprosy, tinea can involve the ears as well and the face, as you can see here. And facial tinea is often not very itchy. Can be photosensitive as well, the tinea on the face. So moving on, so this, what do you think, leprosy or tinea? This is actually leprosy, right? However, this was easier to diagnose because the patient had multiple patches. You can see patches on his upper limbs running right through Che Guevara as well. And these were not itchy. There was a sensory loss. The same patient, you can see a lot of lesions. But it can be quite tricky to distinguish from tinea unless there is pruritus. So actually, this patient came to our clinic with the lesion near the elbow, which is actually a tinea. It was a pruritic lesion. But when we examined, we found the patient had a hypopigmented patch on his arm as well, which is actually leprosy. So common conditions can coexist, right? So we mustn't miss them. Then Pityriasis rosea is another condition. You get annular scaly patches, but it will have what we call a collarate scale, a peripheral scaly margin. And usually, it's multiple patches. It comes over a couple of weeks. And it has what we call a Christmas tree distribution along the back, although we don't often see that in all patients. But it is a transient condition, and after a month or two, it will go away. It sometimes due to the dry scaliness, it can be confusing, but often it can involve the axilla, or it can involve the back, and there will be a colored scale, which might be a clue. Now, urticaria, you might wonder why I'm thinking of urticaria, but urticaria is usually quite itchy, but it's not always red, especially in our skin. As you can see in the bottom picture, the main clue to distinguish, now this is leprosy actually, but clue will be it's more transient. So, and it'll be itchy, right? But sometimes patients come and say it is not itchy, but most majority patients, it's very itchy. And it's more transient, it's moving. It will change over days, a day or two. You can see it changing the shape. Now, atopic dermatitis is another condition to get dry, scaly patches. The typical onset is not at birth, but rather pruritic patches, commonly on the face and the trunk. Now, usually bear in mind, leprosy is not very common at birth because, as I said before, it has a long incubation period. It can take anywhere between 6 months to 20 years after infection to develop the disease. So obviously, it's difficult to get the disease before that. In addition, the BCG gives added benefit of protection. And obviously, the maternal antibodies also probably has some protection. And atopic dermatitis can be quite pruritic, but in the smallest children, they won't be scratching away because they can't do that. Scalp involvement again would be unlikely in leprosy, unlike atopic dermatitis where it is common. Psoriasis also presents with dry, scaly plaques, but the scale would be silvery in nature, often involve the scalp, in addition to the ears, and they might have nail changes, pitting of the nails, mycolysis, cement patches, and so on and so forth of the nails, which will help to distinguish. Cutaneous leishmaniasis also can, especially when it involves the earlobe or the face, they can come with these dermal plaques, which can be seen in leprosy also. But often they come from an endemic area, and if you do a smear, you can distinguish the two. Often leishmaniasis we see in people like, say, Tissa Maharame, Deundara, then Valioya, army soldiers, and so on and so forth. So here are two more patients with leishmaniasis. And this is a patient with histoid leprosy. So you can see again dermal nodules on the earlobe. So it can be quite tricky sometimes. Now, acne. You might wonder why is acne here in the picture, but actually, believe it or not, sometimes it can be confusing. So, acne, as you know, the main distinguishing feature is usually acne patients have comedones. You won't see comedones, obviously, in leprosy. And the lesions are more transient. Within a day or two, the pustules will go and new ones will come like that. So, sometimes lesions like this, leprosy, can come with these dermal nodules around the mouth, around the cheeks, which can be mistaken for leprosy. I'll show you another patient later on as well. So sometimes we also see erysipelas of the face, which can be a bit of an emergency. Now, erysipelas of the face has to be distinguished from cellulitis of the face, which is a more deep-seated infection involving the dermis and the deeper dermis and the subcutis. Now, the Millian sign is a sign which helps us to distinguish erysipelas from cellulitis because in the ear, you don't get much subcuticular tissue. There is no subcutaneous fat. So if you see earlobe involvement, it's unlikely to be cellulitis. It is erysipelas. Right? Now, having said that, now in leprosy also, you can have a similar picture. Now, you can see here erythema involving the face and the yellow. Actually, this is not one of our patients. This is from a journal in another country. This patient was treated several times for erysipelas, and the patient was not responding. And later on, only they found that the patient was having leprosy. And here also, you can see acneiform-like lesions on the cheek, which can be mistaken for leprosy. Moving on to the treatment of leprosy. Right? I hope you all have understood up to now. Please, if there are any questions, please don't hesitate to ask. Depending on the time frame, I will answer them. So from a therapeutic perspective, we broadly categorize as multibacillary and paucibacillary. We don't think about tuberculoid leprosy or lepromatous, not like that. Just two groups. Borderline just multibacillary and paucibacillary. So now, just like in tuberculosis, you can't give just one drug because there is a risk of developing resistance. Patients have to be on long-term treatment. So again, it's very important that they stick to the treatment. So the first-line drugs we commonly use are dapsone and rifampicin and clofazimine. Now, treatment of leprosy is not just doling out a medicine, the leprosy cards. I'll show you what they look like. Rather, it's a multidisciplinary approach. There are so many things we need to tackle in leprosy patients. Right? Now, as I said, we divide as multibacillary and paucibacillary. So multibacillary are patients. According to WHO, they grade as 6 or above lesions. 1 to 5 lesions are paucibacillary. Having said that, since in Sri Lanka, we have easy access to dermatologists, unlike in some of countries like India or Brazil, where there is a large surface area. Here, sometimes clinically also, if it's even one patch, if it's a large patch, by experience, we know just treating possibility means the patient is going to get a relapse. And often they can be smear positive even if it's only one patch. So in such instances, we would be treating, even if it's one lesion, with multibacillary treatment. Even if we have one thickened nerve, we treat with multibacillary treatment. And the smear has to be negative at all times. If it's positive, that means there's a high bacillary load and less cell-mediated immunity. So possibacillary treatment is usually only for 6 months. Multibacillary, 1 year or sometimes even 2 years. So this is the treatment we give. So this is provided free of charge by the WHO. So right now, this is the status quo, but this is going to change in the coming years. For now, we have possibacillary adult treatment, multibacillary adult treatment, possibacillary child treatment, and multibacillary child treatment. The difference is when it's multibacillary, in addition to once a month rifampicin and daily dapsone treatment, we also add clofazimine in multibacillary. That's the only difference, right? So not only drug treatment, so other treatment like physiotherapy is very important, splinting to prevent disability and deformity. That's our target. So that's what we should be, targeting on. So in addition to these, we provide them with certain splints, depending on the type of nerve defect, nerve injury they're having. Also, they are provided with special shoes. We call it microcellular rubber shoes. These are given free of charge to our leprosy patients, especially, if they have foot ulcers or peripheral neuropathy. It's made from a special type of rubber which prevents injury or shoe cuts. And it has a very soft sole to prevent neuropathic ulceration. Then surgical reconstruction in established deformities is also very important. It is still in the early stages in Sri Lanka, but we have done it in several patients. We have sent them overseas and done that. So this is just a clue about just a picture of what can be done. So you can see with surgical correction, the degree of deformity and disability, how much it can be corrected. But just like surgery, it's very, very important that they are followed up with proper physiotherapy as well. So orthotic devices are sometimes provided in patients with established defects to help them with their day-to-day life. So this, of course, is not directly provided by our campaign, but they are referred to the relevant sources to get these, should they have to undergo amputation. So now childhood leprosy. I thought of mentioning a few words of this, but this is very important from more than first for the community physicians, because from the epidemiological point of view, it's very, very important. Because as I said, this disease has a long incubation period, sometimes up to 20 years. So how do we know where we stand with regard to the elimination of leprosy in this country, eradication of leprosy in this country? So because when we see a patient today, a new patient, the patient could have been infected with leprosy from the community 1 year ago, 6 months ago, or even 20 years ago. So we can't get an accurate idea. But if you see a 3-year-old boy with leprosy, we know there has been leprosy spread in the community within the last 3 years, isn't it? So that's why childhood leprosy is a big clue about the disease activity in the community. So I said a lot about leprosy. So I think just to summarize as a take-home message, if you get a patient, suspect leprosy, if the patient has a prior history of leprosy coming with new patches, or has a positive contact history of leprosy, especially if the lesion is over months to years, you won't get leprosy over a day or two, unless, as I said before, if it's a reaction and the patient just noticed the lesion. If he or she comes from an endemic area. Now, in the Western province, we commonly see around Moratuwa, Ratmalana, Mount Lavinia, Dehiwala, Piliandara, Papiliana side. Then Mattakulia, those areas. Kolonnava, Valampitiya, like that. What the levels you get patients. Then I know in the eastern province, so in Sri Lanka, those are the two commonest areas in the western province and in eastern province. Somewhat less in the Nuareli area, but we do see patients in all the districts in Sri Lanka, so all provinces. So coming from endemic area, any change in sensation, hyperesthesia, or anesthesia, or other cutaneous stigmata of leprosy we discussed, infiltrated earlobe, so on and so forth. Unknown causes, trophic ulcers of unknown cause, and loss of motor function of unknown cause, or irregularly thickened nerves, think of leprosy. Leprosy unlikely if the lesions are itchy, very short onset lesions, scalp, armpit, groin involvement. And if there is a significant proximal muscle wasting without sensory loss, again, leprosy is less likely. So if you come across a patient, what should you do? So most base hospital and above government hospitals will have dermatology services. So anything above a base hospital, you can refer. Alternatively, you can refer to us. I'm at the Central Leprosy Clinic of the National Hospital. You can refer to me any weekday, 8 to 4. Or if the patient has any difficulty in coming, we don't actually recommend this to be done as a first line. But as a last resort, you can even WhatsApp the number shown here. It's our direct line at the Central Leprosy Clinic. You can't call it, but you can send a clear picture with high resolution. Then someone will get in touch with you and ask for further details. And that might at least give a clue whether it's unlikely to be leprosy or. And finally, certainly you can contact public health inspector. He will help as well. So thank you very much. So I think there were some, I'll just check whether there were questions. So anything you want to ask me at the moment?
Thank you very much, Dr. Siriwardena. I'm Professor Shamali here. So
Hello.
there were, I think, two questions. One is, just let me go to the question. Regarding the type 1 and type 2 reactions of hypersensitivity in lepromatous leprosy, can you explain the importance in clinical practice?
The importance is now if you take a type 1 reaction, they can come with a sudden swelling of a localized area of skin, like that picture I showed, those pictures I showed. So sudden, painful, red, tender swelling. Sometimes the patient can feel a bit poorly, maybe a bit feverish or out of sorts. So it can be mistaken for things like cellulitis, right? Whereas the treatment should be steroids, right? So that is one. So you might think it's cellulitis. These sort of things sometimes, actually quite often, just with the immune response alone, after some time it subsides. So you might just give antibiotic for several days. Sometimes you might give a pain NSAID. NSAIDs also help. So this might subside on its own and go away. Then you can miss the leprosy patch, right? That's number one. Secondly, as I said, initially they come with a red patch like the picture I showed, but next step might be the involvement of the nerve there. So you saw it was on the forehead, near the eye, and the nose. So if the branches of the, the facial nerve are involved, they can develop acute lug of thalamus. So they can't close the eye. They get tearing of the eye. So they can get acute, it can lead to blindness if you don't treat it early and get the treat the nerve defect early. They can come with sudden onset foot drop because acute swelling of the common peroneal nerve. So then what happens? They might actually, patient might neglect it first of all, or they might think it's a hiria kohitari tadavela kakula hirivatila or something. Or alternatively, it might even be missed if you don't palpate and feel a swollen nerve. And this is something that can be corrected. If you think this is a stroke and just give aspirin or whatever, you can't correct it. But if you give steroids, this is completely reversible in the early stage. So these usually nerve problems, it's difficult to reverse, isn't it? But here, if you detect it early and treat it, it's completely reversible without any disability. Secondly, if you take the type 2 reaction or the erythema nodosum leprosum, due to circulating immune complexes, it can ulcerate, can get infected, they can get glomerulonephritis, arthritis. Usually, leprosy doesn't kill anyone very easily. It causes a lot of disability, but reactions can kill, especially erythema nodosum leprosum patients quite ill. They have high ESR, they can even die from it. So that's why we shouldn't miss it.
Yeah. There's another question. How can we suspect leprosy in a patient with bilateral leg swelling? Any specific features? In a patient with bilateral leg swelling.
First of all, if I get a patient with bilateral leg swelling, yeah. First of all, if I get a patient with bilateral leg swelling, the first thing I will do is exclude the common causes, obviously, unless the patient has a contact history or any other thing to suspect leprosy. So, liver functions, renal functions, cardiac history, albumin, and all that I'll check. If they are normal, then that's a bit suspicious. Often in leprosy, they will have trophic changes, right? So the skin will be dry and ichthyotic. Even that patient I showed you the picture, the skin was very dry. If you look carefully and scaly, the patient might have, most likely will have a peripheral neuropathy as well. So the legs will be numb. If you ask, "Pulungu උඩ ඇවිදිනවා වගේ," they'll say, "කකුල පුළුං උඩ ඇවිදින, හිරිවැටිලා," like that sort of thing. If you check the sural nerve, if you palpate, turn the patient on a prone position, and run along the Achilles tendon, the junction between the 2/3 and 1/3 of the leg. If you palpate, you'll feel thickening of the sural nerve. Obviously, not in all patients, but at least some of them. You have to check the common peroneal nerve. Then often they might have a contact history of leprosy or from an endemic case. So if you exclude everything and exclude all the causes of bilateral leg swelling, please don't forget this. I have seen even specialists missing this. Later on, patient comes with a patch, and then we diagnose. Patient has been investigated before with echo and everything.
How do you handle stigma and fear when disclosing a diagnosis of leprosy in OPD? And also, there's the same question. There's another part. When can a treated patient be safely reassured that they are not non-infectious?
That's a very good question. So let's move to the first one. How do you handle stigma and fear when disclosing a diagnosis of leprosy in the OPD? First of all, the stigma is a major issue. Personally, I would not prefer in this being discussed in OPD. Now, in our clinic, we get the patient down. We try to get confidentially as much as possible and talk to the patient. Now, it's a bit of a dicey situation. Now, in our clinics, we do screen the family members also, right? Now, sometimes, depending on the family circumstances, the patient is scared to tell the husband or the in-laws. They are often living under the same. So it's a bit of a dicey thing. So we have to encourage them to tell their family members to screen them because they're also at risk, especially if the patient is a multibacillary patient, there's a risk of spread from the patient. Even if the patient is not a multibacillary patient and not infective, as I said, tuberculosis leprosy is not infective, but obviously the patient has caught it from a close contact, spent over 20 hours a week, for 3 months to get it. So in that instance, I'm sure the household people also may be exposed to the common source, maybe a next door neighbor, someone coming home, maybe a babysitter. So obviously we have to screen the rest of the family as well. So it's a bit tricky. We can't do it by force. So we have to convince the patient somehow to do it. So it takes a long time, especially our patients. Like when you talk to them, they are in tears often. So due to the stigma, I've had patients tell me, "Why didn't I get diabetes? Why did I have to get this? But this is something curable. Diabetes is not, isn't it?" So things like that. So it's very pathetic. Even the stigma among healthcare workers is sometimes shocking now. In our patients, when we start them on treatment, especially with dapsone, one of the direct side effects are what we call dapsone-induced methemoglobinemia. So we have to, if the patient complains of shortness of breath or headache, we have to check their saturation. So then we send to the OPD, and they're already diagnosed patients. There's a huge resistance sometimes to get it checked because nurses are worried that the pulse oximeter will transmit the disease. Whereas now, when we start treatment in a patient, as I said, it's the lepromatous leprosy or the multibacillary patients who are infected. So once we start them on treatment, once they have taken 3 doses, that is 3 days of treatment, they are not infective. 99.9% of their bacilli are killed, right? Why we treat for such a long time is to make sure we've killed all of them and there is no chance of resistance. But usually with 3 doses, 3 days treatment, they are not infective. And as I said before, even if they are infective over those 3 days, you need a prolonged contact to get it. So often the patient has spent all that time with the home individuals, 3 days is unlikely going to make a difference, right? So in the healthcare sector, it's very important that we tackle stigma because patients often suffer a lot from it. So even in our clinic, actually, we don't when I put my seal doesn't say leprosy clinic, it says special dermatology clinic. So that even if the patient has to take the chit and go somewhere, no one knows that the patient is having leprosy. And we prefer to use the term Hansen's disease rather than leprosy so that, sometimes these things matter. We find sometimes patients don't go to their closest dermatology clinic because they are worried that the neighbors will come and see them there. They go about several kilometers further to a different clinic so that they won't be seen by anyone else. So there are a lot of issues with stigma. Sometimes even with educated people, they don't, I've seen teachers lose their jobs. The principal says not to come to school and things like families breaking up. So it's very challenging. So we have to spend a lot of time per patient to try and sort these matters out.
The
I
other
hope that
question
was
is when
what was
they
asked and
are not
helpful.
infective.
Yeah. So as I said, so even now, tuberculosis leprosy patients are not infected anyway. But even in a lepromatous leprosy patient, you need a prolonged exposure to get it. Now, once you start treatment, now if I start a patient today, Sunday, with treatment, and the patient takes treatment Sunday, takes treatment on Monday, it's a daily treatment, isn't it? So then you take treatment on Tuesday. Once you take Tuesday's treatment, that is 3 days treatment, the patient cannot spread the disease to anyone because over 99% of their bacilli are dead by that time. Right? So 3 days treatment, they are not infectious. And even before treatment, within those 3 days, they are unlikely to spread the disease because, as I said, you need a prolonged contact. So within 3 days, they are unlikely to give it to anyone. Any further questions I wonder?
Sorry, I was muted. So, what are the basic investigations that have to be done before treatment? And
Now,
is
as
it a must? Yeah.
yeah, yeah. Now to diagnose leprosy, to be honest, you don't need to investigate if it's a straightforward diagnosis. You don't actually need anything. It's a clinical diagnosis. But as I showed before, some of those are quite tricky. So sometimes we do smears, even if we know the diagnosis as a baseline. Because when we start treatment, obviously the number of live bacilli should gradually go to zero, goes within, as I said, within 3 to 4 days. And then the dead bacilli also should gradually clear up. So over the months now, we treat 6 months, 1 year, 1.5 years, 2 months, so on and so forth. The bacillary index or the dead bacilli also, the bacillary index is dead and live bacilli. Morphological index is the percentage of live bacilli, right? So the total bacilli we see per high power field should gradually go down. So if it's not going down to the amount we need, it's we have to be careful whether there is drug resistance. So basically, that's one test we routinely do. It's called a smear, where we use a number 11 blade and make a small slit, earlobes, on the patches, eyebrows, on and so forth, and collect the tissue fluid and stain it. So and the MLT gives just the reading. Right? So that is one test we routinely do. Now out of blood tests, now we do tests before starting treatment, not just for diagnosis. I mean, for diagnosis, as I said, in addition to the smears, sometimes we do biopsies. If the smear is negative, if the smear is positive, we don't need anything else. We do biopsies if we are not sure of the diagnosis, especially towards the tuberculoid pole when the smear is negative. Now, in addition to those, we do blood tests, right? Now, the basic tests we do are mainly due to the treatment because out of this treatment, dapsone can lead to problems sometimes, right? So you can get one of the common things we see is dapsone-induced hemolysis. So often during treatment, I would say a significant percentage of the patients, their hemoglobin would drop, often less than 1 gram per deciliter, sometimes up to 2 grams per deciliter. But if your HB is 12 and it drops to say 10, below 10, say 9, 8 like that, then of course we have to seriously consider stopping the dapsone. So in our clinics, we do a baseline full blood count. We repeat it every 2 weeks in the first 3 months, just to make sure you're not missing a dapsone-induced hemolysis. As I said before, in addition, if they get headache or shortness of breath, we have to check for dapsone-induced methemoglobinemia as well. That doesn't always go hand in hand with hemolysis. So oxidative stress to the membrane, cell membrane of the red cell causes hemolysis. Oxidative stress to the iron, in the hemoglobin, that's what leads to methemoglobinemia. So they are slightly different. So if they have a headache or tiredness, we have to check the saturation also. Then we check the liver functions because they can get a dapsone-induced hepatitis, right? So then we also check the renal functions as well. And before starting treatment, we prefer to do the brewer's test because sometimes if your G6PD levels are deficient, you can get a severe life-threatening hemolysis. Another dreaded complication is dapsone-induced agranulocytosis, which can be lethal. So that's another reason why we do the blood counts. Fortunately, it's quite rare. Out of the other drugs, fluoxetine is quite safe. It usually doesn't lead to much problems, but in high doses, it can be cardiotoxic. Main issue is that it causes significant pigmentation, especially if you're on multibacillary treatment. So if you take it for over 6 months, your skin gets pigmented. Patients, especially if it's a young girl, they'll be very worried about it, quite understandably. But we counsel them that usually after you stop the treatment, within 1 to 2 years, it comes back to its previous color. Skin also gets dry and ictiotic with fluoxetine treatment. Rifampicin can cause urticaria and hepatitis. It can stain your bodily fluid like orange colored urine, tears, so on and so forth. But those are the main side effects. So those are what we monitor for blood wise. Sometimes in addition, while we are monitoring the patient, if they say new onset numbness of a foot, new onset numbness, we would refer to the electrophysiologist to do nerve conduction studies as well to see whether there is any progression of nerve damage. So both axonal and demyelinating changes can occur with leprosy.
Do patients need treatment if a patient suspects tubercle leprosy whose biopsy reports negative? Whether they're asking whether it's they need treatment if it's suspected tubercular leprosy if the biopsy is negative.
Usually, if you have tubercular leprosy, often I actually don't need a biopsy. It's clinically because, as I said, it's a good immune response. So there'll be due to the immune response damage to the adnexal structures. It will be anesthetic, anhydrotic, loss of hairs, color change. You'll see all those, but often you have a differential with something else. As I said, you can mistake it with another skin condition, right? So in such an instance, for example, you're not sure that you're mixing up that with an eczema or something, then a biopsy will definitely help to show the difference because in tubercular leprosy, you see a major inflammatory process. You'll see granulomas, right? So in the superficial dermis, you'll see a granulomatous process. So it's very unlikely not to see any inflammation happening in tubercular leprosy. That means your diagnosis is wrong. And one thing though, I usually when I do biopsies, I don't encourage to do punch bar. We take a larger piece because if you take a tiny piece only, you're likely to miss. So if it's representative, if you have taken from within the lesion, if you've taken a significant piece of skin, it's very unlikely to miss it. If you don't see it, it's most likely your diagnosis is wrong. But if it's anesthetic, any of those cardinal signs are there, obviously then you won't even need to do a biopsy, no? Any anesthetic hypopigmented patch is leprosy until proven otherwise. So in such an instance, I wouldn't even be doing a biopsy. But indeterminate leprosy, that very, very early stage, yes, now that is tricky because in that early stage, it can be a vague hypopigmented patch. Sensory loss may not be present. Even if you do a biopsy, often at that stage, what you might see is, around these appendageal structures, around the hair follicle, around the nerve, you'll get a lymphocyte infiltrate only. You won't see granuloma because there has been no time for the immune response. So in that instance, if I'm not 100% sure whether this is indeterminate leprosy, I will just wait and watch. I'm not going to discharge the patient. I will definitely get the patient's details and get him or her back after some time to see what happens. So we see, because even indeterminate leprosy, even if it is that, it often it spontaneously resolves. The patient gets cured, they develop an immune response, right? So there are various studies. In some studies, only 20% going to develop leprosy. Others, it's higher, but so it's variable really. So I would observe a wait and watch approach, and I would get the patient. And often we see it either cures or you can see the patient getting a tubercular leprosy or some other form of leprosy develop. So that is also a sensible approach if you're not sure, because we mustn't forget diagnosing with leprosy is also a significant diagnosis. It's not like saying you got acne or something, no. Lot of stigma involved. You're on a long course of drugs. You need to have so many blood tests done during the course of the treatment. You have to screen the entire family. There are a lot of socioeconomic implications. So as a result, unless I'm sure, I will not label the patient with leprosy, the diagnosis. And we should never say this is leprosy and 2 3 months later there shouldn't be a situation where I say wrong diagnosis and go back. That will really devastate the patient. So we have to be absolutely certain before we put the label and start treatment.
There's another question. Is it reasonable to refer to exclude neural leprosy when a patient presents with numbness of the part of the body without a suggestive rash or other cause for numbness? You didn't hear, no? So whether it's reasonable to refer to exclude neural leprosy when patient has numbness without a rash or any other cause of numbness. Any other
Yes, I
cause for
would still
numbness?
refer. That's
Mm.
I would refer because certainly I would. I mean, obviously, when you examine, I will check with the numbness if it's following a dermatomal pattern or a radiculopathy kind of pattern, or just a very vague ill-demarcated patch. Right, that can be leprosy if it's ill-demarcated, not following a particular pattern like along a nerve trunk or dermatome. Then even otherwise, if it's a localized patch, if you don't know the diagnosis, better to be safe. So I would refer to a dermatologist so we can evaluate. There are sometimes other causes of numbness. You would have heard of this meralgia paresthetica, notalgia paresthetica, due to nerve entrapment. Inframedial to the scapula, you can get due to compression of spinal nerves, where you get this numbness or pins and needle sensation. Same way on your anterolateral thigh, when the nerve, the lateral cutaneous nerves of the thigh cross the inguinal area, in obesity, or due to hernia, they can get entrapped and lead to numbness. So not all numb patches are leprosy, but certainly if it's numb, better to exclude that because we can't afford to miss it. So refer to a dermatologist, and if necessary, we will refer to a neurologist if we are not sure.
One more question. How common is dapsone sensitivity? Dapsone sensitivity, how common it is?
Yes. Now, dapsone causes several different kinds of problems. Now, I already spoke about dapsone-induced hemolysis, dapsone-induced methemoglobinemia. Now, dapsone hypersensitivity syndrome is another serious condition we do sometimes see. It's not very common, but it is a major issue because it can be a life-threatening thing. They come with a rash. They can have other things like eosinophilia, edema, they will have other organ involvement, liver, kidney, so on and so forth. It is life-threatening, so we can't afford to miss. So usually it occurs within the first 6 weeks, like 2 to 6 weeks of starting, even afterwards, less commonly. But if a patient with on dapsone develops any of those symptoms like maybe even a fever, a rash, or patient says they are feeling poorly, something's not quite right during that time frame, we are very, very concerned. So we would, be very careful, follow the patient up more closely. If necessary, do a biopsy, we'll do their blood test and see. There's another similar and overlapping condition called DRESS, which is drug rash, eosinophilia with systemic symptoms, which is also a very similar thing. It can occur with other drugs, also with dapsone. They are very similar conditions. Lymphadenopathy, eosinophilia, fever, rash, organ involvement. So those are two things we have to be very careful when we treat. But fortunately, they are not very common. But I'm not saying that we haven't lost patients. I mean, not in my clinic, but there have been instances where patients have died due to delayed diagnosis. So we have to be very vigilant. And what we need to do is when we diagnose a patient, and when we start on the treatment, that first day you have to spend a lot of time and explain all the side effects and what to do if you develop that. That is the most important because sometimes patient gets a rash, patient gets a fever, patient thinks, make a virus. Virus. So must make it be absolutely clear to them what they need to do if they get anything or what they and also if there's any delay in coming to the clinic, stop the treatment. Stopping leprosy treatment for 1 day or 2 days or even a week is not going to make a major change, right? Because although we don't tell this to the patient, we have certain targets. We tell the patient you can't miss even 1 day's dose. But usually the possible treatment, that is a 6 months treatment, our target is to finish it within 9 months of treatment. And the 12 months treatment, the multifaceted treatment should be finished within 18 months of treatment. So obviously you can see in between, you can missing for a week or two is not going to make a major issue. So we have to tell that stop the treatment, come immediately as far as possible to meet us, or if not, go to hospital and tell you on these drugs. Okay? So if there's any doubt, they should not delay. The communication is the most important thing.
Okay, Dr. Siriwardena, I think that is all the questions for today. That was actually quite a lot of questions. So thank you very much once again for coming in and doing it with a short notice as well. I'm sure all the participants benefited a lot, and we will share the presentation because there's a lot of requests coming to share it. So we will do that as well. Thank you very much once again. Good night to all of you.
Good night.
Thank you.
Yes, sir.